Hello, everyone, and happy Friday. Thank you for joining us on this Friday afternoon. Welcome to today's HEAL Headliners webinar. My name is Jess Mazarek. I'm the program director for the HEAL data ecosystem. And today you get me in two roles. I'm going to be logistical support and housekeeping for the Zoom session, but I'm also going to be moderating. So let's start off with some housekeeping things first. To provide any comments or questions, please open your Q&A, which is located at the bottom part of your screen in case you're new to Zoom. And if you need technical assistance, please type the issue into the Q&A and one of the techs will respond and help you out. Finally, please be aware that the session today is being recorded and closed captioning is available by clicking the CC icon at the bottom of your screen. Okay, moderator role. Here we go. So today I'm really excited about our webinar. It's going to be fantastic. It's focused on data, the currency of scientific progress. Widespread sharing of data allows researchers to ask new scientific questions and speed discovery around novel and life-saving and evidence-based practices. Today's presenters are each leveraging the power of data to directly address the needs of individuals who experience pain and substance use disorders. They're going to share their stories about harmonization toward an end goal of making data useful and reusable for their audiences, even when their audiences are ranging from researchers to providers and communities on the ground. Our first speaker today is Dr. Meredith Adams. Dr. Adams is an associate professor of anesthesiology at Wake Forest Baptist Health. She is board certified in anesthesiology, pain medicine, and clinical informatics. Dr. Adams uses a range of strategies in her informatics research, including economic analysis, machine learning and artificial intelligence tool development, data infrastructure support, and data visualization, all with an eye to health equity. So without further ado, Meredith, please take it away.
Thank you, Jess. And I am also super excited about today's talks, mostly because I want to hear Mark and all the cool stuff they're doing with their projects. Let me just get this up and in our presentation mode. So I'm Meredith Adams. I'm the PI of a project that I'm talking about today, which is part of the Empower Network. And Empower, as Jess explained a little bit earlier, has to do with both chronic pain and opioid use disorder. And what we've done with this network is a little bit different because we have 6 different sites with 11 different R01 level projects that are looking at different questions, but using the same questions to sort of study those interventions. And so we're harmonizing using common data elements and applying these to sort of see what it looks like when you're asking similar questions for different outcomes. And it's really sort of a neat experiment, but as you can imagine, it's a little bit complicated when you get down to the data side of things. One of the things I think is really important is thinking about the why. And when we talk about data harmonization, we talk about all these things in terms of sharing things back with the communities and the science sort of larger world, you really think about, why does this matter to the people that are actually doing the work, whether it's the communities, the partners, the people that are participating in the studies, and what does that actually mean? And so when we're thinking about harmonization, I think a lot of times people are focusing in on the logistics of actually just the data harmonization, but there's a lot of people and idea harmonization that really come into that. And so as we're thinking about harmonization, it's harmonizing what the partners and the scientists think. We're taking those concepts and then harmonizing them with how we want to collect these data, what we're actually doing in terms of the logistics of data collection, and then how might we want to use this later. And the why that it circles back to is the faster we can get these solutions, the more impactful they will be, because science that sits in a journal somewhere on a computer may not really shift people's lives. And I think what we've all realized is that to really change health and medicine, we really need to sort of close that loop in a tighter way, and data is one way to do that. So with our coordination center, we have a couple different things that we do, but they really all actually play into the harmonization. We've got communication, again, where we're harmonizing what the science community and partners and people with lived experience and all different groups are thinking about aspects. We are looking at how we're harmonizing the actual data collection and special things we're doing with that, and then how we actually harmonize, what our end goals and how we want to educate both physicians and patients and just the general community afterwards. Yeah, hold on a second. And so, as I mentioned earlier, we've got these 11 projects that we're working with, but we actually came up with 60 CDE measures that we're working with that actually had over 800 variables. And this process is something where lining these up in a way that made everyone happy. There's a lot of compromise that goes into this. And I think it's just important to realize that the whole goal of what we're trying to achieve is something where people can really feel like we're going after things that matter to important populations. And then we're also doing it in a way that is going to make the science valid and shareable and reusable for future aspects and projects. We use the sort of common things that you think of in terms of with the pain and opioid disorder with our promise measures. We did things where we were looking at like promise proper, where we take these base ones and look at quality of life measures to sort of add stuff. So we really kind of focused in, I use this phrase a lot, but we were really looking for that double Scrabble score or even the triple Scrabble score, where you can make things count more than once. So really get high value for things, asking fewer questions, getting more information. The usual suspects in terms of substance use, in terms of concepts, these are things that we were looking at in terms of what we were screening for, but we also had these sort of gray squidgy areas, if you will, that have actually prompted the funding of a whole new network, looking at what is opioid use in terms of dependence, misuse, and some of these types of things that we really don't have figured out. But we started trying to carve some of those areas into more defined components so that we could start seeing signal and trends with that. But really, I think when we talk about harmonizing and what it went into it, another aspect to realize is that we as scientists, as a collective, everyone fills out their grant, everyone puts this information in, they have their ideas, but then you're looking at this portfolio of ideas and it still may not hit actually what people with lived experience or partners may feel like are the important things. So as part of our kickoff process and what informed our sort of harmonization of ideas, if you will, we really were talking to our partners and trying to see, what do you think is understated? What do you think is stuff that we really should be, highlighting or bringing in ways? And then as scientists, working these projects, our job was to translate this into sort of the best measures we thought would capture those domains and bring those forward. And some of those things were like the stigma measures. This is something we kind of had, but we definitely amped it up. Trauma was something that was sort of there in some of the projects, maybe not all of them, but it definitely is in all of our required CDEs now. Things like economic impact, that is actually us harmonizing with places like the CMS and some of our sort of partners that are in insurance and billing and areas where they want to know what's the economic impact. Because another thing is that you want these to be strategies that providers will adopt and they will use with their patients. You want these to be things that are being welcomed by a community as somebody who's going to be receiving these treatments potentially, but you also need to make sure they get paid for. So if we're going to do this, let's do it well. And so, we ended up bringing in things like social determinants of health and all these other areas where, we ended up with a really big menu of things that we wanted to pull forward. But it was really because we wanted to look at this as something that was multidimensional. And if you're looking at 11 different interventions using the same information, it's not necessarily going to give you all the answers, but you can definitely start to sort of get the seeds of ideas and move things along a little bit faster than if you're waiting till the end of all these projects and then trying to thread things together and hoping that some of this information can be combined. So this is really kind of the sort of gamut of ideas and concepts that we were really building into our data harmonization process with what we were doing and making sure that we were asking questions, whether it was about marital status or sex or gender ID. We had, we included what the common data elements were, but we actually expanded on a lot of these things. And we felt like it reflected what our partners would want to see on a questionnaire. We're not going to make everyone happy, but trying to be as welcoming and inclusive to get this information so we can take better care of people is really the goal. So then on the data side, where this kind of comes in, that's sort of the thought process that inspired everything. We had a lot of opportunity. There's lot of opportunity for us to build in the data space in terms of we built our common data elements into a single REDCap library that has all of these different components so that it was easier to share that out and then share that back. And we have special processes to do that. But some of these things where, say for the Michigan body map, what we wanted to do is make it as easy as possible for people to use it. Follow the HEAL guidance, which was recommending that we use these variable names so that things can be reproduced. What that meant was we had to figure out how to actually label all the body parts using these variables. But the upside of that is our project then connects to the variables in other projects that are using the same body map. So somebody taking the survey just sees a picture and they click on the parts of the body that actually hurt them. But behind the scenes, it does all these extra calculations and does scores for like widespread pain index and other factors that are really helpful for us to sort of do, but it's low burden on the patient, just something we can make easy with the technology. And it's something that we shared back with the ecosystem. We also mapped it to the ICD-10 codes so that if people want to see billing codes that line up with those, you can kind of move things forward. And I think it's one of those ones where there's a lot of sort of back end work on the data side, harmonizing, if you will. But what it means is that it's something that collects information that's useful. It builds another repository, and then it connects to other projects. And then by sharing this back, it means that other people can just take our work and they don't have to spend that time doing it. They could just plug and play, which is what we are all about, is making it easy for other people to do this. Because I mean, it's hard figuring a lot of this stuff out and getting it, close to right. We're never going to be perfect, but we're getting it operational. And then making it so other people don't have the same struggles is something we really try and do. So for us, how we're harmonizing is we're building a data enclave, a cloud computing platform where we're going to be hosting all of our de-identified data for our network. And then it's on this Gen 3 instance, which is a format that's being used in the HEAL ecosystem of the data platform. So we're lined up there. That's its own adventure. We can talk about a different time. But we're also mapping our data to things like the CMS, ICD-10 codes. We're mapping them to concept codes. We're working on mapping them to OMOP, common data models. And then we're sharing everything we do after we publish on it back, because we want people to be able to take advantage of the work that we did and not have to do it themselves. And hopefully they'll take it, build cool things, and we get to share back from them. I think common data elements, a lot of people feel very ambivalent about it. I think they're necessary awesome is where I put them, in that it's something where it can be annoying to have to sort of align, but at the end of the day, the most impactful science is the science we actually use. And we're trying to build our things in a way that lets us actually do that and sort of build forward. And then this is just kind of a screenshot of our in-process development and what we're doing with our data dashboard for the cloud computing, where we're going to be able to look at, say, stigma measures across 11 of these things and sort of build from there. But we can monitor our clinical trial enrollment. It's secure, and then we can do some discovery stuff, which is the goal. And that is the roll through, so that there's lots of time to ask questions or see Mark's awesome presentation.
Fantastic. Thank you so much, Meredith. Okay, we're going to save all the Q&A for the end, I think, so that both speakers will be able to answer questions together. So let me quickly introduce our next speaker, Dr. Mark LaRochelle. Dr. LaRochelle is a general internist and clinical investigator specializing in addiction medicine at Boston Medical Center and an associate professor of medicine at Boston University School of Medicine. As a health services researcher, Dr. LaRochelle aims to learn new information through analysis of large data sources toward developing interventions to improve the quality and value of healthcare delivered. He serves as the director of the informatics core for the Massachusetts site of the Healing Community Study. And I'll turn it over to you, Mark. Thanks for being here. Excited for your talk.
Awesome. Thanks, Jess. All right. Excited to share the work of our group here in Massachusetts, as well as throughout the wider Healing Community Study. All right. And so I've titled this, "If you build a dashboard, will they come?" And engaging communities in data-driven decision-making. for the Healing Communities study. And you'll see where that comes from as we move forward. And so an outline of what I wanted to go over today is provide everyone an overview of the Healing Communities study. Not everyone may be familiar with it. Give an overview of the development and actually a demo of the data dashboard we've developed for HCS. And then talk more about what we've learned and how to engage communities in data-driven decision-making. So Healing Community Studies, a large NIH and SAMHSA funded project. 4 states have been funded, Massachusetts, New York, Ohio, and Kentucky, to work with 67 of our communities that were highly affected by opioid overdose deaths. And our goal is to deliver a community engaged process or intervention to implement evidence-based practices to reduce overdose deaths. So here's a map of Massachusetts. We have 16 communities in Massachusetts, and the communities were randomized in this study. And this is a waitlist control trial. So the experimental timeframe was from January 2020 through June 2022, when wave 1 received the intervention. And that is when the comparison is being done. And we're now actually actively in the wave 2 waitlist part of things. And so the goal of HCS is to reduce opioid overdose deaths, again, through implementing evidence-based practices. We've organized these into 3 main buckets. The first is overdose education and naloxone distribution. The second is increasing uptake of medications for opioid use disorder. And the third is safer opioid prescribing and dispensing. This is an overview of the actual intervention. It's called Communities That Heal, or CTH. And it's a community engaged process. We had 6 phases that are listed here. Really going in, building a coalition with each community, and then reviewing where communities are at, what the evidence-based list of evidence-based practices are, having them develop action plans about which ones they want to implement, and then assisting with the implementation and monitoring, and then ideally moving towards sustainability. Data-driven decision-making, which is what we wanted to talk about today, is a key tenet of the study. And really what we want to do is use data to guide and inform the decision-making in the communities. And I just include a few quotes here from the protocol paper for this study, where we've highlighted that our goal is that communities are going to be using data to make their decisions on which EBPs to deploy and where and how to deploy them. So what are the data tools we had? So phase 3 talks a lot about building and using these data tools. So everyone was to develop what we call community profiles, but also data dashboards. And this was a co-creation process with our community members. The community profiles were really comprehensive outlines of where the community stood in terms of their demographics, what resources were available at the time, what a lot of data and statistics were for their communities. And data dashboards were built to monitor key outcomes over time in each community that could be updated and used to monitor progress. So for the dashboards, it was quite an involved process. So at a consortium level across all 4 states, we developed standardized measures that could be obtained with administrative data across all 4 of the sites. I'll share examples of these and the data they come from on the next slide. So once we developed the measures, we had to develop a supply to get the data feed from each of the data partners, and we do this on a monthly basis. And then each of the study sites develop data visualizations along with the community and update the data monthly to share back with the communities. So here's a list of some of the measures that we developed and put on the dashboard. We get opioid overdose deaths in Massachusetts. We get that from our vital statistics data. We get information on how much naloxone has been distributed to the community. through our OE&D efforts via the Bureau of Substance Addiction Services. We actually get data from IQVIA on how much naloxone is going out through pharmacies. And then you can see some others here, buprenorphine from prescription monitoring program data, and then other medications for opioid use disorder we get from Medicaid data. So a wide array of data sources and data partners, and each one of these required us to develop clear specs about how we were developing and calculating each measure, and then working with our partners to implement those and get us the actual data. So each state built its own version of the dashboard based on the local environment, what technology was there, what communities could use. But here I list hyperlinks, and hopefully we can get these to folks so people can go look, but these are live versions of data and dashboards in each site. I'm going to flip over and actually do a live demo of what's up on our Massachusetts dashboard right now. So this is what you come to on our homepage. Right now, this is live for our 8 Wave 2 communities. And you can, right now I've selected Lawrence, but you can collect, identify any of the 8 communities from this drop-down box. And then this homepage has a summary of 4 key metrics we're monitoring. And these are the opioid overdose deaths over the past 12 months. There were 48 in Lawrence. And this line just shows the shape of the trend over the past 12 months. And if you hover, you can see where it was. So we have data as of March 2023, and that was actually a great month in Lawrence. There were 0 overdose deaths recorded in Lawrence in March of 2023. This is how many units of naloxone have gone out in the past 12 months. So 1,200 units of naloxone, and how many people are on buprenorphine. I'm just going to click on naloxone because you can get more detail as you come in, and this will pull up data at the month level, where the bars represent the kits that went out into the community. And this is a combination of those that go out through our harm reduction programs, as well as those that come through pharmacy. The bars are the total in each month, and the blue line represents the 12-month trailing average to help smooth out some of the noise you see. And so, you know, some optimistic trends from early 2022, it does seem like things are increasing here in Lawrence. We put some summary statistics up in the upper right corner. We have a date slider so people can change the view of what they want to look at. All right. So go ahead and check out each of these these dashboards. They all have a little bit of a different look and some different features, but all feature a lot of the same data. So once we developed these for our Wave 1 communities and put them into place, we got a lot of feedback on it. And not all of it was positive. In our first wave, we required users to have a password and an account. And a lot of our community members indicated that just created barriers to access and use. Just having to go through that, remember the password, and get set up. And so we were able to, in Wave 2, move much of this into a publicly available dashboard where no passwords are required. Some people commented that the lags in the data may make it less useful. So, you know, as researchers, if you've tried to get overdose death data, we're really excited that we've got a dashboard right now in early September that has data through March, but people are eager for more and more recent data. We have been able to get data on buprenorphine from the PMP, for instance, that only is lagging about 6 weeks. So some of the data are pretty recent, but they're not immediate. People also mentioned they had a preference and maybe even trust more locally sourced or programmatic data. They're used to seeing data from their own communities, and these data that were collated from state-based sources took them some time to understand and get used to. And then finally, they were overwhelmed, I think, sometimes with the amount of data and figuring out how to interpret what's there. And they liked having stories from the data to share with the broader coalition. And so taking this feedback, we've evolved our approach to working with communities over time. One of the things we've done in Massachusetts is create what we call data bites, which is where we take observations we've had from looking at the data on the dashboard and turn them into, usually it's a one slide digestible bit of information. This slide shows what we were seeing early in the COVID-19 pandemic. And it looked like, as we were looking across the communities, that buprenorphine counts had started to drift downward in a concerning way. And so we combined the data for all 16 communities here and did a quick interrupted time series analysis. And you can see that pre-pandemic, there was a very clear, consistent increasing trend in the number of individuals receiving buprenorphine in our communities. And then after the stay-at-home advisory, 6 months later, there was a pretty concerning drop of about 8%. And again, with only a 6-week lag, we were able to pick up on this trend pretty quickly, and then report this back and work with our communities to understand what might be happening and see what we could do to work on that. So that's one example of something we've done. And then this is an overview of the action plan process. And I want to give some examples of what we've done in 3 of the Wave 2 communities. But on the left, there's a wide array of different types of data that we put together into a community profile that I talked about. It includes maps of where resources are, drive time maps to different resources, data from administrative data like what's shared on the dashboard, incorporate whatever local data, and then demographic and social determinant of health context from each community. We implemented data walks, which are we take all of this information and go to the community coalitions and pull out snippets of data that we want to present and have them look at, react to, tell us what they think, and think about how that might inform their action plan. Some communities used photo voice, and I'm going to give an example of that to work together. And then once they have their action plan of what they want to do, they build implementation plans, and then we monitor how things are going at each of the communities. So here's an example from a data walk in North Adams, which is one of our rural communities out in Western Massachusetts. This was a map that was created that shows the location of opioid overdose deaths in their community. These are all jittered points so that people could not identify exact addresses. And the symbology here is that the red looking like house is an overdose death that occurred in someone's own house, where the blue house is a death that occurred in someone else's residence. So it turned out here in North Adams that 100% of the overdose deaths actually occurred in someone's residence. So none of them occurred outside or in a public location or in a motel, but they were all actually occurring in someone's home. And when the coalition saw this and had the discussion about it, they noticed that that area in the northern central part of North Adams is one that has a lot of affordable housing complexes and apartment buildings. First responders that were there confirmed that those were locations that people were often coming to respond to overdoses. And they all actually expressed some surprise that all of the overdoses were occurring in someone's residence. So they took this information and built out a strategy to get naloxone and overdose education more accessible in these locations. They partnered with the North Adams Housing Authority. They worked to install nalox boxes in at least 3 locations, and I think maybe more, and then got overdose prevention training for staff members through the Berkshire Harm Reduction community. So moving on to a second example, this is Belchertown and Ware, another more rural community in Massachusetts. And this is a map of the resources. And on the left side, that map is pretty blown up to show a pretty big area that's probably about 100 miles across. And then on the inset over here is looking more at where Belchertown and Ware are. And this key over here tells you what type of things are put pins on the maps. And the yellow, what does exist over here, some federally qualified health centers. But all of the substance use disorder treatment and recovery programs are over here along the I-91 axis, primarily in Springfield, some up here in Holyoke, and a few further north in Northampton. And so Belchertown and Ware being rural and small, one of the things that people notice, you need transportation to access a lot of services. And actually the opioid treatment program using drive time distances is at least 30 minutes away from people living in these communities. So the nearest methadone is a 30-minute drive. And Belchertown and Ware is a town that used photo voice, which is really a process to engage people to use photos, to share their experiences and environment and tell stories about what was happening. And so this is a picture that one participant had, and their quote that went with this, their narrative was, "I've had this Jeep, but I've needed to fix it. But without a way to get to a job, I can't make the money I need to fix it. And it keeps me in this cycle of never being able to get my feet under me." Another participant said, "I had to move to Amherst. I sought out public transportation in Amherst to the sober house there, and the sober house was not the right fit for me. So it was just like I was making healthcare decisions based on convenience of transportation." And I think that's what a lot of people in this area are doing. So the strategy they came up after having this conversation was to implement recovery coaches with low barrier peer transportation. 2 full-time recovery coaches were funded along with a van. They provided recovery rides, prioritizing people getting to MOUD appointments and services. And the other thing they were able to do is provide a lot of support and get to know folks along with those rides. So the last example I'll give is one from Springfield. Springfield is, I think, our second largest city in Massachusetts, and it's more in the western part of the state. And this was one of the data bites that was used in a data walk in Springfield when the coalition was meeting early on. And this shows some really concerning trends in rates of fatal overdose by race and ethnicity from 2020 to 2022. These are the rates per 100,000 residents by 3 of our race ethnicity categories. And the final cluster of columns there shows that deaths among Black non-Hispanic individuals almost doubled between 2021 and 2022. And so when the coalition saw this, they wanted to do a few things to address these disparities intentionally. One of their action plan items was to sponsor 8 Black individuals to complete the Recovery Coach Academy and pay their tuition to that. Another was the observation that they had that some of these deaths may be in people who are using stimulants and unintentionally exposed to opioids, as fentanyl is increasingly identified as a contaminant in the stimulant supply. They also know that Black individuals in Springfield were more likely to be people who use cocaine rather than heroin or other opioids. And so what they came up with was a contingency management program. They located it in a predominantly Black neighborhood, 12-week-long program focused on life skills, naloxone education, which is a pretty unique element of engaging in people who use stimulants, because that was something that, you know, if you're using stimulants and not opioids, that's something people in the past weren't worried about, but now is of concern because of the contamination of the supply, and also some work on substance misuse and mental health. So this is my final slide. The conclusions I take from this are that democratizing data is a key step in promoting data-driven decision-making at the local level. And dashboards are a key step, but simply sharing information on a website is likely insufficient to engage communities without further supports. We've used data bites, data walks, and PhotoVice as tools to help improve engagement with data in our communities. So I'll stop there.
Great. Thank you so much, Mark. Meredith, do you want to come back on and we'll do some Q&As? Yes, all the claps, virtual clapping. Wonderful. I do see we have a question in the Q&A box, so I'm actually going to start with that. And it's a question for Meredith, but I think before we ask that question, which is about tutorials and workshops around using empowered data sets, maybe we should first talk about your timelines for and plan for data sharing and what that timeline looks like. And then you could talk about potential trainings.
Wait, we're supposed to share data? So, like, no, yeah, I know, I had to say it. It's just waiting for it. No, so with Empower, we are obviously, it's a new group project, and like all new group projects in elementary school, we're still figuring things out as we go. And so ultimately the plan is to share the data with the larger, ecosystem. But in the current stage, while we're still actively getting studies up and running and going, with the access is going to be kind of worked out among the investigators investigators, and then ultimately we'll be sharing that. One of the big question marks, I don't know if Jess has an answer, but when we started this, data sharing was different than when we were kind of finishing this. And I don't even know when we finish this project in 3 years, what data sharing will look like for the ecosystem. But our intent is to try and make this a really awesome data set that you can find the things, you can connect the things, you can do all the things with it. But it's how we will have it packaged up, because right now we're building towards, a cloud computing platform. We're bringing another network into it and actually going to be having them use some of the same questions and adding on new questions. So it should be pretty fun. We just have to kind of get to that stage where we figure out how we share that and allow access, but that is definitely a priority. And regardless of the end of the studies, we'd be sharing it back in some format. But I think having it be a cohesive set just adds that sort of interest for folks.
So do you think you'll do trainings and workshops around those data sets when they're ready to share?
Well, yes, the answer would be yes. If that's what the ecosystem wants, then that was what we will be doing, because it really just depends on how we think we can keep it up and running and access it. And I think these are all so new in terms of, like, we aligned our original plan, as I think many people on this call can understand, was not what we were actually doing. We had a nice little kind of simple dashboard that we were planning that was going to be pretty and have some information. This is much more involved. But the behind the scenes is really building the framework and the security to have it be something more robust. And so our hope is that, you can then be looking at projects across the country and seeing these data and coming up with new ideas and hopefully getting sparks for things that people are doing.
Great. Thank you. Okay, I'm going to shift over and ask Mark a question. So you talked about data sources that are quite different than what we're maybe used to as researchers. Can you talk through some of the challenges with using those types of data sources and why the dashboards are such a nice way to share results back to communities?
Yeah, there are a lot of steps with this, right? So I put that slide up to show how many different data partners we had to work with to access all these data, right? And if you're an individual community, especially a smaller rural community, trying to figure all of that out is going to be really hard. And so it was a lot of work for us as a well-funded study to even get that done. So the data are really disaggregated and owned by a lot of different partners. So we had to go to them and get their, our first step was to get buy-in that this was important to share, figure out that we could share it in a way that was met their legal requirements. You'll see all of the data we put on our data dashboard are aggregated at the community level to help provide anonymity. We had to work out suppression rules for some. So if the counts were small, we would suppress the data. So depending on the data source, if the count in the community is under 5 or under 10, we'd have to suppress it. And then, so we worked out access. And then the next thing we need to do as a big group was figure out how we were actually going to measure these things. And it may sound obvious, but it's not super obvious, right? So overdose deaths, luckily, are pretty well standardized in how we identify them from death certificate data. But some of these other things are much more complicated. And so we worked as a group to figure out how we were going to harmonize and standardize our definition of each of these measures. What codes are we going to use? What timeframes are we going to use? And so we'd build standardized processes for doing that. Then, some states had direct access to data. In Massachusetts, we had to basically do it in a way where we'd write code and share it with the data partner who would run it and send us a report, right? So we'd get a feed from the data partner because we couldn't access the data each month, or access the data directly, but needed them to summarize it and send us a report. In each state and each data partner is a little bit different, but I think the power of what we've done here is built a process to generate some really valuable set of constructs that are of import to a lot of different communities. And I think our hope is that a lot of this gets sustained. If you go to the Ohio dashboard, they've actually introduced it throughout all of their counties in Ohio, not just the Healing Communities counties, and have a mechanism to sustain populating that moving forward. Our partners in Massachusetts are excited about doing some of that and have taken some of the definitions and the work we've done that helps reduce the lift to try and start from scratch in doing this. So a lot of work to go in and build that. And I'll come back again to emphasize that I think something that surprised me and maybe not to others was how much work we had to do to get people to be interested in coming and looking at that data, and really take the work to go in to help them build trust in what those data are, and understand what they are, and help them look at it so that we can get the insights we really want that will inform their programs on the ground.
Thanks for going into that detail. I think that's great for folks to hear, some of the considerations that may be a little bit different. Okay, so we have some questions coming in through the Q&A now. I have another question for Mark at the moment. Are there comparison analyses between rural, urban, and or racial ethnic demographics? Actually, I think that could probably be for either of you, maybe.
I can give a speedy on that one. Yes, and so we have adopted the use of the RUCA code, everyone's new favorite star on the CDE block, which is just a coding system that takes zip code and makes it rural versus urban in a coding system that's set up by another US government agency. So it's standardized, and we've got a tool. If you want to go to ruca.wakehealth.edu, you can just put in all your zip codes, it batches things, and then you come up with that. And what we do is we actually generate that for all of our participants. And so it makes our stuff de-identified, because it's another PHI variable that is not, it makes the data set just even better for us. We have other things like using the GUID, which is the sort of standardized way of getting a patient identifier, and some other things. And then the other one, in terms of like I think it was sex gender, our group used the baseline stuff that was sort of like the CDE common data elements that people have, but then we actually went back to partners. And so our gender is male, female, trans man, trans woman, gender queer, non-binary, agender, gender fluid, other, with space for text if you need to fill in and you're not covered by those categories. And we want to hear all things. So we kind of built a broader version of that. So our data, it will have all that available.
Thanks, Meredith, for going into that detail. Mark, do you want to add anything to that for your dashboard?
Yeah, so I mean, we showed one example of some data stratified by race and ethnicity in one of our communities. But one comment I'll make that became clear to us is data, especially for race and ethnicity, are hard to come by, because when you're using secondary or already collected data, because most of the data sources aren't collecting it, or the quality of it is fairly poor. I think this community engaged work is an opportunity to help us have conversations, because the data, it's this cycle, right? The data are actually generated from the community partners that are doing this work, right? And so what we hear is they're constantly asked to create data, give data, right? But it often doesn't cycle back to them, and they often don't understand why or what they're doing in terms of data that just feeds into some massive database somewhere. So I think this, because they've come to us all the time saying we want more data stratified by race and ethnicity, but like our prescription monitoring program does not have race and ethnicity in it, right? We can get things by age, but not by race and ethnicity. And so, it's led to conversations, but we still are way behind in most of our administrative data in being able to collect these data. So a lot of room for growth there to improve the data that we are collecting, so that we can do these important analyses.
Thanks for adding to that. Okay, another question for both of you. Do you feel the need to manually prepare data summaries that are lay friendly, and how do you do that? How do you do that or plan to do that? Sorry.
So for our group, we're still in, I think, an earlier phase of the life cycle than Mark's group. And so we're not quite at the lay summaries because we've not yet completed the projects to actually share the summaries. But I think what we do know is we want to bring our community partners that we have across all the different studies and sites in the network. And then it's not one size fits all, because there's some people that will like things as a summary. Some people will like things as a podcast. Some people will like an infographic. Some people say, don't tell me anything. And so it's really just going back and saying, what menu of ways would you like us to communicate this to you, and how would it best suit your purposes? And I think we've learned that, what works well for one group, you may have to have multiple strategies is really, I think, the take home we've learned.
Mark, we saw the data walk summary slides that you all create in your talk, but maybe you want to expand on that a little as well.
Yeah, so we found those useful tools for communicating with our research team and the communities. We are in the analysis phase right now, which is really exciting for healing communities. And we're starting to have conversations about how do we communicate, right? So we're writing a research manuscript, but that's going to have a lot of technical lingo in it. And so it's how do we summarize these results back to make it relevant to the community? And how do we place the community's participation in this study in context with what the overall results of the study are? So we don't have perfect answers to that question yet, but we are intending on doing that. And I'm sure we'll learn a lot as we go through that. But we will definitely be preparing materials to share the information with the community that are different than what we're going to be putting into a peer-reviewed manuscript.
Actually, so something I saw earlier when I was looking at instruction into authors was a unique paper type that I hadn't seen before, where they have a category for like a lead author that's a community member of a technical data study. Jamie Open has those. And so they actually want the community perspective and having the lead author be somebody who's there, which I think is really kind of a neat thing with a lot of these data activities that we're doing. I was like, that's cool. We should use that. But now I've given myself a lot of competition here, but for that role. But I think that that's a neat way to sort of incorporate that might be a blend, and then be something to build more talking points from.
Yeah, that's great. Love that. And I have to put in a plug for Heal Connections, which is a group that's working across Heal to help investigators that are funded by Heal think through these kinds of questions about how to share your research. So more broadly than just with the research community, which you both have been doing and thinking about really well. So thank you for doing that. Okay, this is a question for Mark, but I think it's actually better. Are any specific data on the Kentucky Healing Community Study? But Kentucky has a Discord, right? So maybe we can share.
Am I able to put those in the chat? I don't even know. Like, do people see that? But it's hcs.uky.edu. I don't know if I put stuff in the chat, if people can see it, or if I can put it somewhere so people can grab the hyperlinks.
Yeah, maybe we can have the IQ team send them out with the after the webinar. They send a follow-up email, I think.
Okay.
Tom says you can put it in the chat, so you can put
all
it
right,
in
I'm going to put it in the chat. And okay, so there's one for each state here.
Oh, they can see our chat, but they can't chat to us. So if you make it to everyone, they'll see it. Yep, there it goes. Perfect. Thanks. Okay, and I'm gonna go ahead and ask Meredith a question about partners actually while you're typing, because the next question I have is for you too. So Meredith, you mentioned idea harmonization with your partners. Can you talk a little bit about who your partners are, and what unique perspectives and concepts they brought to the table that influenced your data collection and harmonization processes?
Okay, so I want to clarify actually just the use of the word partners, which sounds really vague, but are a group that normally is called people with lived experience actually preferred for our study to be called partners. So we call everybody partners. Sometimes it's we partnered with, the different societies or with different groups. And so the partners actually included people with lived experience with chronic pain, addiction, people that had various different life experiences, but then also people from advocacy groups, as well as insurance companies, CMS, and really a wide range. And we use those to inform, as I said, both content, it's not necessarily that they were saying, we really feel like you should use the PC, this trauma scale kind of, but they're like, we think that trauma is important and it's something that would be something that we'd like to see. And some of that, what that's informing is the study design, but then our team is also working on sort of educational modules and things like that for like physicians in training and other people in training, like ED physicians and such, to work on things that they felt were maybe underrepresented concepts in their education, so that maybe we could bring that back. So we're coming at it from a bunch of different directions, and it's really informed how we sort of shaped the questions we asked, as lengthy as it is. We got to the end of it and people are like, this is a lot. And we're like, yeah, but what do we cut? Right. So we have required, which is, in every population that you could possibly ask these, everyone agreed to ask them. And then there's a whole bunch of supplementals that we've asked if you wanted to ask the, 7-question version instead of the 3-question version. So longer form or more in-depth things like spirituality scales or different aspects of stuff.
Thank you. Okay, Mark, this one's for you. Based upon your experience rolling out the 4-state HCS dashboards, have you found that the inputs necessary to develop the dashboards are fairly consistent or standardized? If the program were to be rolled out to more of the impacted United States, will there be efficiencies to be gained that will allow for quicker and cheaper rollout, for example, standardized databases, templates, interfaces, etc.?
Certainly. I really hope so. We'll be able to share our metrics and the specifications, I think code. And so these were data sources that were pretty consistently available across all 4 states, and many of them have, right? So I know all 50 states have prescription monitoring programs. We all have vital statistics data for overdose. I think all states we use ambulance data. I think all states are doing that. Medicaid data should be available in all states. So yeah, so we do hope that this is a template for scalability and adoption in other states.
That would be fantastic. Okay, I think there are no more questions from the audience. I have managed to sneak in several of my own questions, or a few at least, which has been great. And so I'm going to do one last call for questions and wait for a couple of seconds, and then maybe just we'll finish up a few minutes early. I think everyone would be okay with that on Friday afternoon. Okay, going once, going twice. All right, thank you so much, Mark and Meredith, for being with us. Oh, how can we merge all the dashboards? Very fast typo, thank you.
I have no idea. Right now they're each independent, but.
Okay, great last question. So let's give Mark and Meredith a round of applause, and thank you so much for being with us this Friday. I hope you both have excellent weekends. I think we have a few more closing housekeeping things, but thank you, thank you. Look at all the little claps, yay, wonderful. Yes, so I hope that all of you can join us at our next HEAL Headliners webinar. Uh-oh, where'd the slide go? It is October 6th from 2 to 3 p.m. again, and we will hear from 2 more fabulous HEAL researchers. So thank you all for attending today, and everyone enjoy your weekends. Thank you so much to Mark and Meredith, and have a fantastic weekend. Thank you all.